So for my common conditions project, I am basing it off of an orthopedic clinic setting. Once I graduate, this is the setting that I would really like to go into. It's the setting that I have personally enjoyed the most, and it's the one that I could see myself making a career in. So all of my five common conditions are based off of injuries that I have observed to be the most frequent in an orthopedic clinic setting. Since I am currently involved in an orthopedic clinic setting, this is where I drew my information of, and this is what I have seen the most of. My first pathology is going to be rotator cuff tear. Mechanisms of injury for rotator cuff tear are falling onto an outstretched hand. They may also develop from overuse or repetitive activities. Most commonly, this is seen in overhead athletes, for example, baseball. They're not only the repetitive motion of throwing the ball back and forth and all of that, but pitchers specifically, the deceleration phase of their pitch is really what can cause these injuries. So some signs and symptoms of a rotator cuff tear are limited range of motion due to pain, specifically with overhead activities, reaching for something overhead, trying to throw a ball overhead, anything that requires the shoulder to move above 90 degrees is going to cause pain and limit that range of motion. Muscle weakness when lifting or rotating the arm, and crepitus while moving the shoulder. Special testing for rotator cuff tear. All of these came from our special test book. The empty can or supraspinatus tear, sensitivity ranging from 44 to 53, specificity ranging from 82 to 90. This test has a high likelihood of ruling in the pathology since the specificity is so high. The drop arm test, sensitivity 8 to 35, specificity 88 to 100. Again, same reason, since the specificity is in that 88 to 100 range, this test has a good indication of ruling in the pathology. The Gerber lift-off test has a sensitivity of 17 to 92 and a specificity of 60 to 98. Since both specificity and sensitivity reach into the 90s, the Gerber lift-off test has a high likelihood of ruling in and also ruling out the rotator cuff pathology. So once a rotator cuff has been sustained, what do we do next? Well, we have to control inflammation. And in the inflammatory phase, which is the first phase of healing, this is crucial. So what I would do is, I'm a big fan of the intermittent 20-minute ice pack application, a good way to control inflammation and try to keep it down. A good modality to use for this is the Game Ready machine. I have had exposure to this in my fall 2020 setting. All the athletes that came in really liked it, and I really liked it because it made them feel comfortable doing their exercises after. So Game Ready for 20 minutes with medium compression. And then exercises to do during the inflammatory phase, just to gain that range of motion back. One that I found could be helpful for rotator cuff repair is the sleeper stretch, 3 times a day for 4 reps. Doing it in all 3 positions of that sleeper stretch can really help regain that range of motion back into the shoulder. During the proliferation phase, some exercises that I feel could be helpful would be to strengthen the surrounding musculature with resistance bands, completing 3 sets of 8 reps for standing rows, internal rotation pulls, and external rotation pulls. Again, trying to regain back some of that range of motion while also strengthening the musculature that attaches to the shoulder. A modality that can be helpful during this phase would be ultrasound. The 5-centimeter sound head, since it's a little bit of a larger area to cover, 0.5 intensity for 10 minutes on a 100% duty cycle, and we're going to want that 3 megahertz so that it penetrates a little deeper and helps warm up the musculature around the rotator cuff and really helps promote healing in that area. During the remodeling phase, we can move on to sport-specific exercises, whatever those may look like for that specific athlete. A bench press and tricep curls with weights. obviously start with a lower weight and then progress up through the weights as their healing phase longens. And a modality that I feel could be useful during the remodeling phase of this specific injury would be electrical stimulation. 20 minutes on an interferential current with a 50% duty cycle. Turn up the intensity until the clinician sees a muscle contraction. If the patient can tolerate more than that, turn up the intensity until a stronger muscle contraction is seen or until the patient has reached their limit. I feel this could be really helpful for promoting healing in the area, getting blood flow back into it, really stimulating those muscles and trying to get them working again in the correct way. So for prevention and maintenance plan, part of the prevention of a rotator cuff tear would be to work out the lower extremities. Since one of the mechanisms of a rotator cuff tear is overuse of those muscles on the shoulder, work out the lower extremity. You know, you got an arm day and a leg day. Vary between the two just so those muscles don't get too overworked too quickly. Also, another prevention technique would be to stretch out the shoulder before and after workouts. Given my sports background of dance and cheer, I am a strong advocate for stretching. I fully believe that if muscles are warmed up properly, then it really does help bring down that likelihood of an injury. However, once a rotator cuff tear does happen, we got to maintain, you know? So we're going to start with controlling inflammation with some ice, placing the athlete in a sling, and then obtain some imaging for the rotator cuff tear. Once they've come to the athletic trainer, said what happened, you collect signs and symptoms, do your special testing. If you really think it's a rotator cuff tear, go ahead and send them to get an MRI just to verify that that is what's happening. So if it comes down to it, we got to have some surgery. In some indications for surgery would be a patient has a limited range of motion or severe pain from the tear, or a full thickness rotator cuff tear verified through an MRI. Outcomes of the surgery are a successful reconstruction of the rotator cuff. Once that cuff tears and it's no longer functioning the way it should, you want to get it back to functioning the way it should. Goals post-surgery: achieve a full range of motion, a 5 out of 5 strength, and limited tenderness to palpation. Once the patient has achieved all 3 of those goals, they should be ready to return back to their sport-specific activities and back to sport. My second injury that I'm going to be discussing is going to be a meniscus tear. Mechanism of injury for a meniscus tear, pretty straightforward, very similar to an ACL actually. Plant and cut or rotational twisting with the foot on the ground, essentially that plant and twist mechanism. Signs and symptoms of a meniscus tear: pain along the medial and lateral joint lines, catching or locking of the knee, limited range of motion, and something that is lesser noted with a meniscus tear but does happen could be a giving out of the knee, as according to the patient. Special testing for a meniscus tear. All right. So we have the McMurray's test, which has a sensitivity of 27 to 71 and a specificity of 29 to 96, giving it a high likelihood to rule in the pathology. Apley's compression test, sensitivity of 16, specificity of 100. So I wouldn't necessarily use this test to rule out the condition, but definitely to rule it in. And lastly, Thessaly's test, sensitivity 80, specificity of 91. Thessaly's test is good to both rule in and rule out this pathology. Treatment plans. So during the inflammatory phase, again, we want to keep that inflammation down, try and keep the patient as comfortable as we can. Ice bag for 20 minutes, and then reduce swelling and edema with electrical stimulation, preferably a TENS type electrical stimulation with a 50% duty cycle for 30 minutes. Turn intensity up to where a patient has a small muscle contraction, but it's not painful. So if you turn that intensity up to where you can see a small muscle contraction, but it is bothering that patient, turn it down to the highest they can tolerate without pain. And then again, some exercises during this inflammation period. passive stretching of the quads and hamstrings. We want to try and regain as much range of motion in the knee as we can, but also stretching out those quads and hamstrings will prevent further pulling on that meniscus. During the proliferation phase of healing, I would choose to use ultrasound to promote healing and aid in breaking up any scar tissue that might have been formed. I'm going to go ahead and use a 1 megahertz here. We don't want to penetrate as deep just because that meniscus isn't really a high, it doesn't have a high chance of tearing again. And so we want to use 1 megahertz just to promote some healing in the area, get some blood flow in there, and help promote what healing has already taken place. I would use a 3 centimeter sound head just because those medial and lateral joint lines are a little bit of a smaller space to try and get around. A 1.0 intensity, 50% duty cycle, and do this for about 7 minutes. So workouts that we can do during the proliferation phase, squats without weights and single leg raises with an ankle weight. Just trying to strengthen up the quads and hamstrings, again, so that it can help stabilize that knee joint. During the remodeling phase, we're gonna do some squatted weights, some weighted squats, and cutting drills. These are essentially return to play activities. Again, with the weighted squats, go ahead and start with a lower weight and then work your way up to the higher weights. And a good modality I feel that we could use during this time would be scraping. Scraping to break up any scar tissue, and especially if this athlete has had to have surgery, scraping will really help break up that scar tissue around their incision sites. All right, prevention and maintenance plan. A good way of preventing some meniscus tear would be to have the athlete wear protective knee braces and to help minimize the likelihood of a meniscus tear. I know that plant and twist mechanism is sometimes hard to avoid for certain activities. I do feel like having a knee brace would help limit some of that forceful rotation of the knee. Also, educate athletes on how the injury occurs. If they know how a meniscus tear happens, they could be more self-conscious about their movements and about how their body is, rotating, contracting, all different kinds of muscles during practice and competition. So once the injury has happened, again, maintenance, we're going to ice the knee. We want to keep down inflammation and swelling as much as we possibly can. Have the athlete wear a brace for practice and games, and strengthen the musculature around the knee. So for surgery, surgery would be indicated if the patient expresses painful clicking and catching in the knee, also indicated based on MRI findings. Since working in an orthopedics clinic, I have learned that MRIs can reveal a lot of information about soft tissue, and it can really help narrow down injuries and what specifically is going on inside the joint that we can't see using x-ray, or it can even verify what we think is going on with special testing. Outcomes of a meniscus injury, obviously a successful removal of the meniscus tear. Once that tear is gone, we can start working on strengthening up, regaining our range of motion, and working that athlete back to a level that is acceptable for competition. And again, restoring a pain-free range of motion and gaining that 5 out of 5 strength. My third pathology is going to be carpal tunnel. This one may sound shocking, and in all honesty, I was really surprised to see it in this setting. However, we have had multiple patients come in that have complained of numbness and tingling in the hand, and through collecting a thorough history, evaluating signs and symptoms, even getting some imaging done and doing special testing, carpal tunnel is actually really common. So mechanism of injury for carpal tunnel, maybe not as exciting as some of the other injuries, but activities that involve a lot of repetitive motions, such as typing, repetitive use of vibrating or heavy equipment, such as a jackhammer, and then assembly line work, all major factors in contributing to carpal tunnel. Some signs and symptoms of carpal tunnel: weakness when gripping objects, pain or numbness in the hands, tingling in the fingers, or a burning feeling in the fingers. So some special testing we can do for carpal tunnel are Phelan's test, sensitivity of 77, specificity of 40. So having them do Phelan's, if the test ends up being negative, it's a good way to rule out that condition. I wouldn't necessarily use it to rule it in. Reverse Phelan's test, sensitivity 42, specificity 35. These numbers really aren't all that great. However, if you do get a negative Phelan test, you can always do reverse Phelan's test just to make sure that your findings of Phelan's test were accurate. And finally, Tinel sign, sensitivity of 82 and a specificity of 89. I would definitely use this to rule in and out carpal tunnel. It's much more reliable than the other two. Treatment plan. So during the inflammatory phase, have the patient wear a wrist brace, ice for 15-minute intervals, and take breaks from repetitive activities. We want to avoid what is causing those symptoms, and we want to avoid what could possibly be making it worse. During the proliferation phase, we're going to work on wrist flexion and extension with some passive stretching. This might seem kind of trivial. However, stretching out the musculature around the wrist, and it can help loosen up what could be occluding those nerves. Again, we can also use ultrasound to help loosen soft tissue structures. Using the 3 centimeter sound head, a 3 megahertz frequency, 20% duty cycle with a 0.5 intensity. I understand that the 3 megahertz frequency would penetrate a little deeper. However, with the 20% duty cycle and the 0.5 intensity, it won't cause as much of a thermal effect, and patients should be able to gain a therapeutic effect from this. During the remodeling phase, we're going to do some wrist flexion and extension exercises against resistance, possibly with a resistance band, maybe even a small weight. Try and work up the strength in the forearm a little bit. Grip strength activities. We can put a rubber band around the fingers and extend the fingers, or we can give them a stress ball and just have them squeeze on a stress ball a handful of times. And then a modality that would be helpful during this would be a TENS unit. Use TENS to help alleviate pain during the strengthening phase. Put it on a 50% duty cycle for a 30-minute treatment time, and then turn the intensity up until a very small muscle contraction is seen, or until the patient asks the clinician to stop. Prevention and maintenance plan. So first, prevention is just going to be have the patient take frequent breaks from typing or some of those repetitive activities that they could be participating in. We can also have them get a more ergonomic chair or desk to help alleviate any of the occlusive conditions that might be causing. During maintenance, we're going to do a wrist brace during work and some stretching to help loosen up tight structures that could be occluding the nerves. So surgical intervention. Surgery is uncommon for carpal tunnel. However, that does not mean it doesn't happen. Indications for surgical intervention would be that the patient is unresponsive to conservative treatment, or it could be dependent on MRI findings if they find that something is just too tight to not be treated with conservative management. Outcomes of the surgery would be to release the space that is occluding the nerves, restore proper feeling into the hand and fingers, and regain a full pain-free range of motion. My next pathology I'm going to talk about is an SI joint pathology. Mechanism of injury for an SI joint pathology is a forceful lumbar extension or an axial load with abrupt rotation. So signs and symptoms of an SI joint pathology: low back pain, pelvis and glute pain, numbness, tingling, or weakness in the lower extremity, a feeling of leg instability, not so much in the ankle or knee, but more around that hip joint, and honestly, a disrupted sleep due to pain. We've had quite a few patients come in that have had SI joint pathologies, and one of the signs we look for is not only pain and numbness and tingling down the legs or along the waistline or the gluteal area, but Also a disruptive sleep pattern. You know, if your back hurts, you're not going to be able to sleep well at night, and that can help guide clinicians along the correct path to diagnose this. So some special testing for an SIJ are the sacroiliac joint stress test, which has a sensitivity of 60 to 69 and a specificity of 69 to 70. Both of these could be used as reliable measurements to rule in and rule out the condition. Then we have Gane-Lyn's test, which has a sensitivity of 50 to 71 and a specificity of 26 to 79. I would more so use Gane-Lyn's test to rule in the pathology rather than rule it out. And Faber's test, sensitivity of 63 to 100 and specificity of 16 to 77. I would more so use Faber to rule out the pathology since sensitivity reaches up to 100. So a treatment plan for an SI joint pathology during the inflammatory phase would be to apply an ice bag for 20 minutes, and then also educate and coach the patient through some pelvic neutral training. This might seem a little silly at first, but if we can establish a pelvic neutral type body language, then maybe we can help alleviate some of the stress that's going on with the SI joint. This also could be done with some multifidus recruitment exercises. And again, we can also accompany the pelvic neutral training with some assisted diaphragmatic breathing recruitment exercises. During the proliferation phase, we're going to do some flexion and extension stretching of the spine. So not only are we wanting to recruit the muscles of the spine, we also kind of want to relax and stretch out those muscles so that they're not putting as much tension on the SI joint. Some exercise you can do, a single leg raise, 3 sets of 10 reps. Again, it just helps, not only does it help strengthen the musculature surrounding that SI joint, it also helps strengthen the musculature of the legs so that maybe those legs won't pull on that SI joint as much as they are. And then a good modality for the proliferation phase, a moist heat pack for 30 minutes. Place some moist heat pack over the SI joint, make sure the athlete is comfortable and properly draped. But getting that heat pack on there will help produce heat around the area and can help loosen up and maybe help relax the muscles around the SI joint. During the remodeling phase of healing, we're going to do some dead bug exercises. I recommend 3 sets of 8 reps and some bird dog exercises, also 3 sets of 8 reps. These exercises are good for, in all honesty, recruiting muscles around the entire spine and around the SI joint, and it helps maintain some stability and balance for the patient as well. A good modality to use at this time, electrical stimulation. Again, make sure the patient is okay with it. And I would advise a TENS unit type of electrical stimulation just to make sure that the clinician is protecting themselves and that the patient does feel comfortable only having 2 pads placed on them. We're going to go with a sensory level type TENS with a 50% duty cycle, a 30-minute treatment time. And again, we're going to turn up the intensity until a small contraction is seen, and then we're going to decrease the intensity by 10% so that we just get those sensory effects and help control some pain that might be going on during the remodeling phase. So for my prevention and maintenance plan, we're going to have the athlete stretch before workouts, practices, and games. As I have said before, I am a strong advocate for stretching. I feel like it warms the muscles up properly and helps get them ready for whatever the athlete might be about to put them through. And again, we're going to educate athletes on how to properly perform workouts and activities to avoid an injury. Too many times have I heard about people getting injured in a weight room because they did a squat the wrong way, or they, did a tricep curl with too much weight on it. Making sure that the athletes know their limits and know how to properly perform these exercises is going to play a big part into preventing injury. So for maintenance, we are going to remove the athlete from participation, apply an ice pack to the low back area, and then we're also going to try and stretch out that low back a little bit to see if we can alleviate any of the pain they might be feeling. So as far as surgical intervention goes, surgery might be indicated if they are unresponsive to conservative treatment or if they have been unresponsive to any type of injections. Working in the orthopedic clinic, I have seen a few spinal injections, and I have been in the room when spinal injections were recommended to patients. I've also been in the room once patients have gotten the spinal injection and come back and, tracked their progress through that. I have seen some great progress with spinal injections, and I have also seen no progress with spinal injections. It really all depends on how the individual patient would respond to it. So outcomes of the surgery would be to relieve any SI pain and decrease any point tenderness going on around the area. So for my fifth and final condition, I'm going to be discussing a shoulder labral tear. Mechanism of a labral tear would be falling onto an outstretched arm or suddenly lifting something too heavy, which can cause an eccentric contraction exerted on the biceps tendon, which can cause some really harmful damage to that labrum. So signs and symptoms of a labral tear would be catching of the shoulder with movement, a dull throbbing ache in the shoulder joint, pain with lying on that specific shoulder, and pain with lifting the arm. If you have a tear in your labrum, it's gonna hurt to lift that arm above 90 degrees. So some of the special testing that can be done for a labral tear, the grind test has a sensitivity of 42 to 53 and a specificity of 80 to 93. Definitely use this test to rule in the pathology rather than rule it out. The Klunk test, a sensitivity of 44 and a specificity of 68. I think this one would more be used to rule in the pathology rather than rule it out, but I would definitely save this one for one of the later tests to be used. The Crank test, sensitivity 34, specificity of 75. Since it does have such a low sensitivity, I would not recommend it to rule it out. I would recommend this test to rule the pathology in. And lastly, we have O'Brien's test, a sensitivity of 67 and a specificity of 37. O'Brien's test is a good test to use if you would like to rule out this pathology. So for treatment plans for the inflammatory phase, we're going to do a game ready for 20 minutes with medium compression, again, trying to get that swelling and inflammation under control as quick as we can. Do some passive stretching to regain some range of motion. And one of the exercises that can be done during the inflammatory phase is wall slides. 3 sets of 5 reps to have the athlete face the wall, place their arms on the wall in front of them like so, and then slide them up the wall just as far as they can go without hurting or injuring themselves. During the proliferation phase, we're going to use some electrical stimulation, more so on a motor level this time. We're going to do a 100% duty cycle, and we're going to turn up the intensity until a muscle twitch is seen, and we're going to do this for about 20 minutes. And again, once that muscle twitch is seen, you can continue to turn up the intensity slowly to the athlete's tolerance. Some exercises we can do, we're going to do some strengthening exercises with resistance bands, some extension pulls, flexion pulls, internal and external rotation pulls, really trying to work that range of motion while also regaining strength, and some stabilization exercises. For example, have the athlete lay supine on a table and have them hold a weighted ball above their body and first get them used to that. And then once they're used to that, you can apply some extra force to it if need be. Again, just help strengthen up that shoulder and regain some stabilization in there. During the remodeling phase, we're going to use scraping to loosen up some scar tissue. Again, especially if they have had a surgery to help correct this labral tear, scraping is a really good way to loosen up that scar tissue around the incision sites. And then we're going to start working our way up to weights. So you can start them on a bench press, starting with a light weight and working up to heavier weights. We can also start with some prone flies, 3 sets of 8 reps. Again, maybe starting with like 5 pounds and then working our way up from there. Prevention and maintenance plans. So in order to prevent this injury, coach athletes to try not to fall on an outstretched arm. I know this may sound silly, but again, if we can educate athletes on how these injuries occur and ways to avoid having these injuries occur, then I feel like it can do nothing but help. Make sure the athlete has a proper warm up before practicing games. Again, it'll help prepare those muscles for that eccentric contraction that they could be putting on it. And it just helps better prepare the body for whatever it's going to be put through overall. Maintenance after a labral tear has been done. Ice the shoulder, place the arm in a sling, and then have imaging complete to determine the type and size of the tear. Depending on that, it could indicate surgery, it could indicate some conservative treatment, but getting an image done is always a good idea to see what exactly we're dealing with. So a surgical intervention for a labral tear. Surgery is indicated if the patient is experiencing severe pain or has a limited range of motion. Also indicated if the patient expresses painful catching or clicking of the shoulder, as well as MRI findings. Again, I am a big advocate on MRIs. I do think they can provide a lot of information that we wouldn't be able to get otherwise. So once the surgery has happened, outcomes of the surgery are going to be a complete lesion repair. Surgeon's going to go in and do everything that he or she has to do in order to correct that labral tear. Afterwards, we are going to restore a complete pain-free range of motion. Mechanical symptoms such as catching, clicking, popping in the shoulder should be gone. And we want a full 5 out of 5 strength in that shoulder. Once all these criteria have been met, I believe the athlete should be cleared to go back to practice games and should start their return to play process. Alrighty. Well, that is it for my common conditions. I hope you enjoyed, and these are my sources. So thanks.